Treatment of steroid-sensitive nephrotic syndrome. Nephrotic syndrome is, by definition, massive proteinuria, more than 1 gram per square meter per day, or in adolescent child more than 3.5 gram daily, and massive proteinuria and consequent hypoalbuminemia less than 3 gram per liter, or its in its absence is edema. So it's common in the boys through 2 to 3 times than the girl, but in the adolescents the age difference may not exist, and more common in the childhood 2 to 10 years. It is more common in the Asian ancestry in UK and Canada. The 90% of the nephrotic syndrome is primary idiopathic, that is, you do not know the cause. 10% there are secondary underlying cause presenting with nephrotic range proteinuria like IgA vasculitis, C3GP, Alport syndrome, infection-related GN, Alport, and so forth. The primary nephrotic syndrome is our concern. How do you treat? Prednisolone is by far the now most effective drug. 60 mg per square meter per day. Total maybe up to 660 mg. And in German people they use 80 mg. So given for daily dose, maybe single dose, maybe 2 to 3 divided doses. Usual practice is to give single dose, because single dose does not hamper the HPA, hypothalamic pituitary axis. There is no less suppression, and toxicity is said to be less on this regard. Followed by 4 weeks, usually patient goes into remission. By 2 weeks or so, 80%. By the 3 weeks or so, rest 10 to 15% are resistant. So by 4 weeks, if patient has remission, you go on giving for 6 weeks. This is the standard like current practice globally. So afterwards, you give it alternate day, every alternate day, 40 mg per square meter per day in every alternate day, and for another 4 to 6 weeks. So giving beyond 6 weeks is not found to have any benefit, and less than 4 weeks, is also found to have inadequate immunosuppression, thereby more relapse in future. So what happens if you give in this sort of treatment, but patient goes into remission? So 25 to 30% of the patients that do not have second attack in their lifetime, rest do have relapse. But in fact 50% of the patient relapses infrequently, and some of them turn dependent. So relapse patients, how do you treat? Infrequent relapses means less than 1 or less relapse in the next 6 months, and less than 3 relapse in less 12 months is called frequent relapse. So more than 1, more than 3 is called the frequent relapse, and some of them are steroid dependent. How do you define dependent? Those who have frequent relapse within the 2 weeks of discontinuation of steroid or during the alternate day of prednisolone. So and they are quite toxic because of the huge amount of steroid medication. How do you treat the infrequent relapses? Infrequent relapses, they are to be induced again by 60 mg per square meter per day, total dose 60 or 80. And when patient goes into remission for 3 days, you go for alternate day and give it for 3 to 1 month. Before deciding on steroid, make sure that patient has infection free, or you have to detect infection, and asthma free, asthma in remission. They are the must. Otherwise you won't be able to decide the amount of steroid, the duration of steroid, and even disease definition would be difficult. How do you treat your frequent relapse? There need to be steroid threshold, defined steroid threshold, and that threshold should be given for longer time. So in doing so, you have some amount of toxicity, especially in the first 6 weeks. Long daily dose prednisolone quite high, so they are possible. And counsel the parents. At that time, child may eat little bit more because the steroid induced your increased appetite. he may grow a little bit laterally, and but the height is usually compromised because of the steroid toxicity. And then but lateral growth obesity, a little bit abdominal type of obesity is a little bit common in the steroid taking people. The spontaneous remission, nephrotic syndrome, fast attack or subsequent attack, there may be possibility of spontaneous remission. But in good amount of cases, if you do not give the prednisolone, there again relapses. So treating them, the infrequent relapse or FRNS, whatever SDNS should be nice. So if you do the biopsy of these cases, what is the your histology like? Common is SSNS. They are steroid sensitive. Your 90% of the SSNS or MCD, minimal disease, they are steroid sensitive. And FSGS, by far the next worst sort of histology, they are found in around how much? 30% of cases and something. And the prognostic is a little bit different. Only 10 to 30% of them are responsive, less not steroid sensitive. Other histology are mesenteric proliferative, membranoproliferative, and membranous. So response pattern depends upon the your amount of proteinuria, your PCL level, and complete response. You have less than 0.2 gram per day proteinuria, that is normal, insignificant, you have complete remission. In those cases, you have normal albumin like more than 3.5, and the reverse is the case when it is 0.2 to 2 gram proteinuria daily, you have partial remission. And in those cases, you do have your albumin between the 30 to 35 something. So and there may be a little bit of edema. So this is how you do treat SSNS. Steroid sensitive nephrotic syndrome, basically it is the immune disorders of T cell dysfunction, and we know that T cell is helped by the B cell. They call it TB crosstalk. The prednisolone affects over here, and thereby your controlling infection and immunological disturbances. Asthma, the HLA linkage with asthma and nephrotic syndrome is described. So it's quite common, and in developing nations like us, we have frequent infection and asthma. They are to be addressed, otherwise patient will not go into remission. Why there is frequent infection? Because you have albumin loss. At times you have non-selective proteinuria, you have gamma globulin loss, and IgG has been low, and you have interferon loss, you have steroid, you have the hospitalization, you have hypovolemia and splenic hypoperfusion, and you have this complement loss in the urine. So there are 8 or 10 reasons why a child with nephrotic syndrome has infection, frequently pneumonia, upper respiratory, peritonitis, UTI, and younger kids it is sepsis. So they are to be addressed to have the really good remission of the disease-free state in steroid sensitive nephrotic syndrome.